Occupational Therapy for Promoting Positive Pelvic Health Outcomes, a Biopsychosocial Approach. Hello and welcome to my capstone presentation. My name is Hannah Mueller. I am an occupational therapy doctoral student in my third semester at Concordia University, Wisconsin. This presentation will explore the results of the first two chapters of my capstone, which are my needs assessment and my literature review. My goal is that anyone interacting with this presentation will have a clear understanding of what I have done so far and what I intend to do. To help meet this objective, I have included an agenda of what to expect through this presentation. First, I will introduce the site at which I will be placed for my capstone project. Then I will overview the strengths, weaknesses, opportunities, and threats, or SWOT analysis I conducted earlier in the semester. After which, I will introduce the mechanism of change. I will then introduce the topic and provide some background, followed by the results of my literature review and the solutions I propose. The site where I will be privileged to conduct my capstone project is a pelvic physical therapy clinic located in Whitefish Bay, Wisconsin. The site is called Pelvic Health and Wellness, and it serves the greater Milwaukee area. The clinic is centralized in a semi-urban area and equipped to meet the needs of the community through skilled services and hand-selected resources. Pelvic Health and Wellness is spearheaded by its founder, Dr. Lauren Beecher. A doctor of physical therapy, Beecher has also received her pelvic rehabilitation practitioner certification and leads a team of 2 other physical therapists in treating the pelvic dysfunction of the men, women, and children in the Whitefish Bay area and cities surrounding. The staff expresses their passion for providing services to people from all walks of life experiencing pelvic dysfunction. Types of dysfunction serviced by this clinic include but are not limited to urinary incontinence, prolapse, pelvic pain, vulvodynia, constipation, endometriosis, and urinary urgency. The clinic also offers services for individuals who have undergone gender reconstruction therapy, as well as a holistic fertility program called Mercier. The clinic excels in one-on-one client care. Clients are screened and treated based on personal goals developed with their therapist, ensuring client autonomy. Initial treatment sessions are double the usual length, allowing therapists to understand client stories better and create a comfortable environment. Speaking with Dr. Beecher in my needs assessment also informed me that there are numerous opportunities for client advocacy, even through something as simple as referrals. Thanks to their location, which is another strength of the clinic, the therapists are in close contact with other disciplines that they are able to regularly exchange information with on behalf of their clients, demonstrating their genuine care and investment in their clients' well-being. The agency and autonomy of their clients is unique to this clinic and provided through the relaxed nature of evaluation session planning, where the client has significant say in what they want to achieve and how they want to achieve it through therapy. Client motivation is also a strength, as most clients seek treatment enthusiastically at this clinic due to the clinic's strong reputation. This indicates a high level of adherence to the interventions introduced. On personal reflection, I identified that the holistic models and frameworks unique to me as an occupational therapy student are a strength to this capstone that will allow me to approach interactions and planning from different perspectives at once. I'll be able to consider mental, physical, and emotional factors simultaneously. Using holistic and client-centered perspectives to guide my work and interactions will strengthen my ability to connect with the populations focused on in the literature and consider multiple factors to well-being. The emphasis on function I bring as a student OT is another strong tool for the success of the program, as it provides a focus on the practical implications of pelvic health care. There are multiple opportunities to apply occupational therapy strengths within the clinic's interdisciplinary setting. Dr. Lauren and I discussed the potential for group interventions to enhance community involvement and patient interconnectedness. Mental health is a critical area for development, with the clinic needing to explore new avenues of care beyond one-to-one sessions, including in exploring biopsychological factors will contribute to this holistic perspective this review aims to achieve. There is also a unique opportunity at the clinic to provide a biopsychosocial perspective on some of the weaknesses previously stated. Dr. Lauren also identified that OTs present an effective alternative to solely addressing performance and engagement deficits through a biomechanical model. Specifically for the implementation of treatment within this population, Dr. Lauren and I concluded that an emphasis on mental health would be especially valuable. The opportunity to apply the strengths of occupational therapy to an interdisciplinary clinic is one Dr. Lauren found applicable to the needs of the clinic. One threat to the clinic is the lack of use of outcome measures. This can lead to a disconnect between patients and their understanding of health progress. This clinic doesn't use them specifically because they aren't needed to justify services to a billing or insurance agency. Without these measures, patients miss opportunities to engage in their healthcare meaningfully. Additionally, harmful language and misconceptions around pelvic dysfunction can deter clients from seeking help and accurately describing their experiences. Because these are such intimate issues, people aren't often eager to talk about them. This can create harmful vocabulary and even damaging sayings around a topic that should be approached more gently. Another threat to this program specifically is my own inexperience as a clinician. Because at this point I will only have experienced 2 semesters of fieldwork, there is much I'll have yet to learn and certain nuances to treatment that I will be unaware of. Based on the results of the needs assessment, I have identified a few mechanisms for change. First is an increased mental health focus by integrating mental health support and group interventions to address psychological and emotional impacts of pelvic dysfunction. This holistic approach will hopefully help in reducing anxiety and improving overall well-being. Next is community involvement. My intention is to connect women together so that by building on previously mentioned topics of agency and autonomy, they can support each other and regenerate and change the conversation around pelvic floor dysfunction, promoting a more positive vocabulary. Fostering community connections to provide support and enhance the sense of belonging and mutual encouragement among patients is very important with this point. Lastly is the incorporation of outcome measures. Introducing standardized and unstandardized outcome measures to track progress and to help prove to patients exactly what they're accomplishing. This helps patients understand their improvements. It'll boost motivation and allow for more precise adjustments to treatment plans. During pregnancy, a woman goes through many physiological and psychological changes. These changes can lead to many unwanted symptoms. One crucial aspect of maternal health is that we often overlook pelvic functionality. Pelvic dysfunction is a term that covers various physical conditions affecting how the pelvic floor works. I conducted this literature review to dive into how pelvic dysfunction impacts women physically, mentally, and emotionally through and after pregnancy. I use specific search terms and strategies to gather literature that reflects the multifaceted nature of pelvic dysfunction, aiming to provide a holistic perspective. For this review, I used prenatal and perinatal interchangeably, as well as postnatal and antenatal, to align with my search strategies. This review is driven by the limited general knowledge of pelvic floor disorders among women, which can lead to negative birth outcomes and complications. Additionally, environmental factors such as trauma and discrimination can also contribute to these complications and pose significant risks for pregnant women and those recovering from childbirth. Including and exploring these psychological factors will help me achieve a comprehensive view in this review. For the purpose of this literature review, I selected 15 articles out of the many that were screened and some that were left out from the original search process. I removed any duplicates or protocols for incomplete study designs, such as outlines for how a randomized control trial would be performed. The databases that I used were EBSCOhost, Cochrane, and PubMed. I implemented mesh search terms and Boolean operators to refine my results. Overall, participants of the study included women who were pregnant and above the age of 18. There was one study that included women up to 60 years old. Participants with any outstanding medical conditions were excluded, especially psychiatric conditions, anything that would affect their ability to give birth. Many participants were also excluded if they were expecting twins or triplets. A single fetus pregnancy was the general expectation for women included in the studies that I reviewed. Pelvic floor dysfunction has a significant impact on prenatal and postnatal populations. This impact can even contribute to negative birthing outcomes and decreased quality of life. Over the course of a woman's pregnancy, the strength of her pelvic floor muscle decreases as the body prepares for labor. This decrease in muscle strength usually leaves antenatal and perinatal populations susceptible to pelvic dysfunction. Pelvic dysfunction can present in a lot of different ways. All have significant impact on the quality of life. Sometimes it might be urinary incontinence, sometimes it might be fecal incontinence. Both are linked to gestation, and both of which are positively impacted by the implementation of pelvic floor therapy, meaning that pelvic floor therapy improves the prognosis of those conditions. The research also showed links between vaginal delivery and increased urinary incontinence. These effects are also mitigated by pelvic floor therapy. The significant improvement in groups who receive pelvic floor muscle therapy all are linked to quality of life outcomes as treatments that manage pelvic floor dysfunction. Antenatal pelvic floor therapy specifically is an area of research that is severely limited. These gaps in the literature often make it increasingly difficult for healthcare providers to take preemptive action against negative birth outcomes and prevent the onset of pelvic floor dysfunction. Both the perinatal and postpartum period, but the postpartum period especially, is an emotionally vulnerable time when women will experience many emotional and hormonal changes. That's why combining mental health principles with pelvic health care is a much needed cognitive behavioral strategy for mitigating depression and anxiety in prenatal and postnatal populations. Psychological factors are special determinants that stand to affect maternal well-being. Multiple psychological factors in conjunction have implications for increasingly negative outcomes, including nausea and vomiting. So the combination of poor psychological factors can make other factors even worse. The care women will receive from healthcare providers during gestation has a profound impact on their mental health and stability, which in turn has a profound impact on their overall well-being. Providers carry a distinct responsibility to protect the mental health of perinatal and antenatal populations and mitigate the discrimination and differential treatment that is reported by many women seeking obstetric care. The effects of psychotherapy on mental health factors, including depression, anxiety, and quality of life, have been proven to be positively impactful on postpartum populations. There's also evidence to support interpersonal psychotherapy in group settings for both perinatal and antenatal women. Preventative psychotherapy measures are especially positioned to help prevent adverse mental health effects of childbirth and parenting even before the onset of postnatal depression. Preventative measures are very important. The interception of postpartum depression could mean a higher quality of life for women recovering from birth and avoid the process altogether of having to treat the mental condition retrospectively. Women in the process of pregnancy or birthing are exposed to contextual experiences that leave them at an especially increased risk for developing trauma. Whether this trauma was pre-existing to the pregnancy or occurred with the onset, it has severe effects on birth outcomes and well-being for both mom and baby. Women with sexual trauma have been found to be even more likely to seek overly intensive prenatal care, which actually results in unhealthy parenting styles and sometimes even birth complications. This means that women with this specific type of sexual trauma are coming into the clinic more and more often, and this is causing difficulty in their birth and in their home life. Screening for trauma in the early stages of pregnancy is a way to mitigate these outcomes. This also comes with the challenge of ensuring early admittance to a care facility, which can be very difficult. It also comes with the challenge of keeping your patients adhered to evaluations. Perinatal women are especially susceptible to trauma and discrimination because they're going to more visits during a period of stress and expectation. They are in a hospital or a clinic more often in general. Further susceptibility is presented in women who report experiencing discrimination based on age, insurance, and finances while receiving prenatal or obstetric care. This shows how circumstantial and time-sensitive pregnancy and trauma are together. Education on pelvic health concepts and how to perform pelvic health exercises are very important for preventing pelvic dysfunction and protecting health and well-being both before and after birth. Understanding pelvic floor dysfunction for perinatal and antenatal populations is so important to avoiding pelvic floor dysfunction later in life. Very large risk factors caused by labor and delivery support this need for education, specifically in pelvic floor settings. This is important for medical providers, for prenatal and postnatal women, so that they can avoid having to deal with pelvic floor issues later in life and treat them retrospectively. Overall knowledge of pelvic floor disorders is lacking among women, especially in areas that are more rural. This makes it incredibly important that these women being pregnant and experiencing pelvic disorders have an understanding of what is happening to them, when most often than not they don't. This deficit in knowledge and understanding of conditions that severely impact health and well-being is evidence enough to inform further research and education. The research also indicates that knowledge is even more limited in the implementation of exercises than just the conditions in general. The training of women, they don't have the resources or inclination to seek out that intervention for themselves, and it's the responsibility of healthcare providers to assist them in that way. Approaches to perinatal and antenatal care that incorporate biopsychosocial health factors have a positive impact on well-being and quality of life. This allows us to consider holistic ways to honor women's values, habits, and their situation. Interventions that are designed to target multiple facets of maternity are shown to be the most effective in equipping women during the gestation and postnatal periods. Social factors as well as personal factors, psychological factors in general, like anxiety, have proven to be stronger predictors of quality in pre- and postnatal care than traditional health markers like BMI, body mass index. This is showing how the approaches that we're using as healthcare providers to engage with prenatal and postnatal populations may not be the most effective, and a shift towards more holistic outlooks might be beneficial. Tools like the Mother-Generated Index, which is an outcome measure for prenatal women, is supported by current literature as an emerging positive subject-based resource for use in late pregnancy. But it only begins to address the desperate need for holistic pre- and postnatal outcome measures. The utilization of outcome measures similar to the Mother-Generated Index, ones that consider maternal factors and encompass social, emotional, and environmental factors, these are the most successful in providing insight into a woman's maternal needs. More holistic approaches to pregnancy also reflect how a woman's needs changes in this time as she goes through the different trimesters and stages of pregnancy. As both her and the baby progress physically, there are more than just one outlet for promoting their health and well-being. Studies that characterize HPA axis dysfunction, for example, recognize that dysfunction is a possible risk factor impacting birth outcomes, but the lack of dedicated research addressing holism in pregnancy care leads to inconclusive results. Implementing a biopsychosocial model into prenatal mental health would meaningfully contribute to preventing suffering for both mom and dad who might be having a difficult time. Again, mitigating negative birth outcomes and negative maternal outcomes could be achieved through a biopsychosocial model. Stages of pregnancy that are earlier are the most important time for the implementation of holistic outcome measures and interventions. These promote the most positive outcomes, and findings suggest that early screening for psychological factors like anxiety and trauma history, even social context, these can help identify women at risk for inadequate care if we catch them earlier on. My intention with this Capstone project is to conduct a group session with women attending the clinic. While patients may be receiving physical care, this interpersonal group will meet more than just bodily needs. The group will explore and personalize connections between mental, physical, and emotional health. These groups will connect women attending the clinic who have a common interest. By fostering conversation around a difficult topic, these groups will pioneer their own pelvic floor vocabulary. A tool to contribute to the clinic through and after the program will be a mental health and efficacy outcome measure library. These measures can be used by clinicians and patients within the group or within traditional treatment sessions. My proposition is a regular meeting of 7 to 10 pregnant women where they will learn from each other and grow in their understanding of the connection between mind and body through a structured meeting. The results of this literature review overall suggest that the events of prenatal and postnatal periods have a significant impact on women. This impact is more than just physical, it's mental and it's emotional as well. It can be readily addressed within the scope of occupational therapy practice by also addressing barriers to engagement and having a functional focus. By modifying interactions to restore lost function, we can achieve this biopsychosocial approach. By applying both holistic and biopsychosocial models and frameworks to the needs of prenatal and postnatal populations, care can encompass the unique environmental effect of this period in a woman's life. Limited understanding and general fear of pelvic dysfunction and options for treatment impacts autonomy and agency for maternal populations. It also indicates another area where support is needed. Promoting positive patient-clinician relationships through therapeutic use of self generates an opportunity to change the negative and fearful stimuli surrounding pelvic health care, also addressing the discrimination and fear that goes into preventing retrospective care. Furthermore, addressing trauma in pelvic health settings is very important to the success of treatments. Trauma-informed care is a contributing factor to treatment adherence and attendance. These outcomes will directly impact the well-being of perinatal and antenatal women, and their birth outcomes must be informed. Thank you so much for tuning into my presentation.